As a patient, for example, me, I'm going through some issues where I can't be happy. I'm feeling sad all the time. I don't have energy to wake up and do my daily things, and nothing makes me happy. So in that case, going through some kind of therapy or communication or having just a communication help, how it changed?
There is a self-stigma within themselves. That means they feel they are weak. And then there is a perceived stigma that the other people might think that I am weak. Plus there is actual stigma, other people saying that, okay, this person can't even cope with this, or this person has got the history of depression, this family has got the history of schizophrenia, I'm not going to get my son married to that family, or this, all that thing.
Correct, social stigma.
Yeah, even within mental health field there is a stigma, plus the mental health is given the less priority. All that things needs to be revisited in Nepal.
Thank you so much, Dr. Bikash, for your time today. I really would like to thank you because I was thinking for a very long time to have someone who has in-depth knowledge in mental health so that we can share that knowledge. Thank you very much for your time. And let's start with your brief introduction.
Thanks for this opportunity. Yeah, truly speaking, nobody can have in-depth knowledge. Yeah, just that I know a little bit more extra than the general population.
Correct.
Yeah, in the way that I can help them.
Yep.
Yeah. So my name is Dr. Bikash Shrestha. Currently, I'm working in the both public and the private. I work as a psychiatrist. So I do 3 days in Nepean Hospital in the public.
Okay, sure.
And the 2 days I do a private practice that's in the Kellyville Private Hospital.
Okay, sure, sure. Doctor, how long you been practicing in Australia?
So I have been working in the mental health field in Australia since 2012.
Wow, long journey.
Yeah, it's a long journey.
Doctor, I can kind of relate because we both come from Nepal, same country, and then mental health is not really spoken or discussed in our community. Have you find any difference in regards to awareness back in our country, Nepal, and here?
So in Nepal and here, mainly in the eastern country and the western country, there is a big difference between the way the mental health present.
Correct.
Because of the stigma and all that thing, in the eastern country, like the seeking help for the mental health is very less common to that in the western population. And also in terms of the nature, like eastern population are more introverted, while the western population are more extroverted. That means in the western population, like if I'm working in the hospital in the public, then the people come telling that I'm feeling suicidal, I'm not able to cope, all that thing. But in Nepal, hardly anybody will come to the hospital and say I'm not being able to cope, I'm feeling suicidal, or I'm feeling depressed. In Nepal, most of the time the people come with the somatic complaint, like, okay, not only Nepal, most of the eastern countries, somatic complaint, like, okay, I'm having a headache. And that headache extensively investigated. They go to the neurologist, they got this thing, that thing, or they have got the chest pain, they go to the cardiologist, they do an ECG, they do echo, everything. But nothing organic cause found. And most of the time, like the depression or something, they do present as a somatic complaint as well. And finally, the cardiologist or someone, then they refer to the psychiatrist, which is again not commonly practiced in Nepal. Like what I have seen is, even the cardiologist starting some antidepressant because they couldn't find anything organic there. And then they are starting the antidepressant to the patient. So in Nepal, it's more of a introverted presentation, while here it is extroverted. And on top of that, in Nepal, like it's a close family, like a joint family. There are like the mother-in-law, there is a daughter-in-law, all different conflict. And then the power imbalance, the power hierarchy, in which they can't express. And so a lot of the things they keep within themselves, within their heart, or within themselves, which they are unable to communicate or unable to express. And in the long run, what happens is, these are all, truly speaking, the neurotransmitter, all that thing, they need some channel out. And something happens and then suddenly they faint. or suddenly they have got this syncopal episode, or they have got the seizure episode or something. Yeah, and they come to the hospital. So this presentation, the conversion disorder, which is quite common in Nepal, like while I was working, did my internship and all that, other my experience in Nepal, the presentation like that is very common. So these are the main difference we have in between the Eastern population and the Western population, the way they present, the way they seek help. This is the major difference that I can see.
Yeah. So, doctor, when you say they don't come with any symptoms, that means they were not self-aware of having those symptoms, or they don't have a knowledge to describe, or they are scared of that social stigma. Okay, if I'm going to go to the doctor with these symptoms, they might call me crazy woman or crazy man, or something is wrong, or she does this all the time. What do you think? Why people are not open about it?
Now, this somatic complaint, truly speaking, is not voluntary. They are not faking it. They are actually having it.
Okay.
They are actually having a headache. They are actually having a chest pain or whatever, tingling numbness sensation in the limbs or anything. It's not they are making faking or they are doing voluntarily. If they have a fight, suddenly they collapse or they have got this fainting attack, it's not that they are faking it. It actually happens. It's involuntary. Why? Because all this stress they have been through. Yeah, and all this neurotransmitter, all this thing, they need a channel out. And how do they channel out? It's presenting as a somatic complaint. Yeah, and the other thing in Nepal is more of a stigma.
Correct.
Yeah,
Correct.
the stigma associated with that, and then the nature of seeking help as well. Like if I have got a mental health issue, I'm the weak person.
Yes.
Yeah,
Correct.
I can't deal with this, even this simple thing, all that thing. So there is a self stigma within themselves. That means they feel they are weak, and then there is a perceived stigma that the other people might think that I am weak. Plus, there is actual stigma, other people saying that okay, this person can't even cope with this, or this person has got the history of depression, this family has got the history of schizophrenia, I'm not going to get my son married to that family, or this, all that thing.
Correct. Social stigma.
Yeah, the stigma very common in Nepal. Yeah, and the symptom, the somatic complaint, the somatic symptoms the patient is having, they are not faking. It's not voluntary. It's involuntary. They are actually having it.
Going through it.
But when they do all the different investigation, yeah, all blood tests, CT scan, ECG, nothing organic could be found.
Okay. So, doctor, why they don't go to in first place to psychiatric or even some therapists? What is the reason they are not going that path to start with?
Now, truly speaking, the awareness, mental health awareness in Nepal is very less.
Correct.
When I was working in Nepal in mental health, like when they present, most of them are like a book case. What you see typically in the book. If we say the schizophrenia, like a typical hearing voices, actually responding, like even a lame person can say, okay, this is unwell. When they reach to that point, most of them, they seek help. But over here, they seek help during during the beginning. And that's number one, the awareness is less. Number second, education is less. And also the services. Like the seeing a psychiatrist, it's truly expensive here in Nepal, the financial thing and all that thing. Lack of resource. Like if you look at Nepal, like psychiatrists will be based mainly in Kathmandu, Pokhara, like major cities.
Correct, in major cities
not
only.
in the village or anything.
Correct.
And then therapist, hardly any therapists in Nepal. While I was working, I didn't recollect people going to therapists. Like we had a psychologist in our hospital where I was working Manipal Teaching Hospital in Pokhara. The psychologist was mainly for the diagnostic test, like doing all the questionnaire rather than providing the therapy there.
Correct.
But I don't know, things might have changed now because it's been many years now. Yeah. And on top of that, I think the government, the resource, the priority that government is putting, like in Nepal, over here, the government, like mental health, lots of budget there, all that thing. But in Nepal, like very little budget. Yeah, so.
Yeah. So a few things such as education, awareness, and plus from government sector, they need to fund more around mental health education like
And
we have
even
here.
there is a stigma within the medical field. Like while I was working there, after the MBBS, you do the internship, and the people and the doctor, everybody, like almost everybody, either they are planning do surgery, cardiology, neurology, very hardly will put the psychiatry as a priority.
Oh
Yeah,
wow, why
even
not,
within
doctor?
Nepal, even within the medical field, there is the stigma there within the medical professional there. And I remember, like when I did my internship, it's a 1 year internship where you do 3 months pediatrics, 3 months ops gyne, and all that different rotation.
Correct.
Mental health rotation was only 1 week.
Oh wow.
Yeah, but over here, like it's like a long rotation for internship and all
Correct.
that thing. So even within mental health field, there is a stigma. Plus, the mental health is given the less priority in Nepal. Like even within the, I think even the curriculum, all that things needs to be revisited in
Correct,
Nepal.
correct. Because it's such a big sector, and then looks like from even the education department hasn't been looked at. Um, Basically, okay, it's nothing. We have very less people, only 1 week internship, and that's it,
Yeah.
which is very disappointing, isn't it, to see. Whereas in Australia, it's even from government sector, so much fund, and then education from the basic they go through a lot. And even I'm a registered nurse by myself, and even I did not went to the mental health. There is so much study into it, and there is so much compulsory placement we need to do it even to become a registered nurse. So I think that's something government should have done more, isn't it?
So a lot of things need to change. It needs to change not only from the baseline, from the top, from the government, from the legislation. Like over here, we have got the Mental Health Act. Like
Correct.
if I have to admit someone against that person's wish, like that person is mentally ill and it's a risk to himself or herself or to other people, then if I see, I put that person under the Mental Health Act.
Correct.
Yeah. Then within 12 hours, another accredited person, either a doctor or the accredited person, must see and say whether that person is detainable or not. And within practicable time, like within a couple of days, a psychiatrist need to see. So 3 people have to make opinion that this person needs admission. Only one person decision, we can't involuntarily admit anyone. It's not
Wow.
that the person come, we lock that person in the mental health unit. No. We have to show that person is mentally ill. We have to show that the person is a risk to himself or risk to other people, or there is significant other risk, or that's the least restrictive measure. We have to demonstrate these 3 criteria, and the 3 people in which one is a psychiatrist has to say that, okay, this person needs an admission. Even after that, the person is taken to the tribunal within the practicable time, like within a week or two. And finally, we have to tell the magistrate in the tribunal that why this person needs involuntary admission. They will have their own legal aid. The family has got their thing to say. The patient has got their thing to say. Finally, it's up to the magistrate to decide, okay, this person needs involuntary admission to this duration, all that thing. So, but in Nepal, what happens? When I was practicing there, family brings it. If the family thinks patient is mentally ill, oh doctor, this person needs to be locked up, the person is locked up. Where is the Mental Health Act in Nepal there? So where is the human rights there? So
Okay.
a lot of things, it has to change not only from the baseline, from the awareness. So from the baseline awareness plus from the
The
legislative,
legislation.
yeah, all that thing. Like while I was working in Nepal, people are locked up from the family ways. Yeah, because the family thinks the person is a risk to themselves. So a lot of things need to be changed.
And there is not any medical intervention or any therapist has gone. They just decide, okay, this
Yeah.
person is not safe.
And over here, like once we discharge the person from the hospital, there is a community support there.
Correct.
Depending on the need of the patient, if the person is a case management, the case manager is appointed. They have got the regular psychiatrist visit, appointment in the community.
Right.
Plus, if the person needs a short-term follow-up, then acute care team follow-up. If the person needs the other support, then like NDIS, all that thing, social worker support will be provided by the case manager team so that the person can be linked with NDIS, all. So there is a long ongoing follow-up.
Correct.
In Nepal, I hardly remember, though my practice in Nepal was very brief, I hardly remember any community team there for the mental health follow-up or anything. It's like the family, person comes in, we get the person admitted in the hospital, discharge is the family. To give medicine or blah, 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 all that thing, it's completely on the responsibility of the family. So no community resource there as well. And even in the hospital, like when we get someone admitted in the hospital here, then they have got this medicine, plus we are providing the psychological therapy, usually in the private, but in the public it's less compared to the private. But they have got the other, like a approach to the library there is a gym there, the hospital where I work, in the inpatient unit. So they have got the library there, they have got the gym room there, they have got the quiet room there are lots of other activities, plus the other activities are going on. That's in the public. In the private, they have to do all this psychological therapy like CBT, DBT, what the person is, like Tai Chi, all that thing that's happening every day. But in Nepal, it's medicine, medicine, medicine when the person gets admitted in the hospital. So these are the difference, I think, that needs to change in Nepal. But the good thing, I'm not only talking about the bad things in Nepal, the good things in Nepal are, number one, in Nepal, the family support. Well, very good family support. Like initially when I started here in Australia, like the dad has got the house, mom has got the house, or even the girlfriend has got the house, but that person is homeless.
Oh wow, correct.
Yeah.
Yes.
But that doesn't happen in Nepal.
No.
Like the family comes, they admit the person in the hospital and say that we are not taking this person back. We can't cope with him. And then we have to involve the social worker to try to find the accommodation and all that thing. That doesn't happen in Nepal. Like such a good family support, family dynamics, all that thing, which is plays a big more therapeutic role than the medication.
Okay. Sure.
Yeah, and that's one thing, one of the best in the Eastern community that I feel compared to the Western. And here it is like the more nuclear.
I agree with that. But it would be nice to have those family members who are actually providing care for that person to have some kind of knowledge.
Yeah, that's
rather than
correct.
just being emotionally attached. If they will have actually any kind of knowledge, clinical especially, that will help, isn't it, doctor?
Yeah.
Okay, sure. I know we have discussed a little bit about Nepal and how the mental health works or the system in place in Australia. But in general, doctor, what is mental health and why it is so important?
It's a very broad question.
Sorry to put you in that stage, but I feel like everyone says mental health. But what is mental health and why it's so important?
Yeah. Now, basically, it's hard to define what is mental health. It's like, so you have got the brain, that's the anatomical structure. Like you have got the heart, you have got the lungs, that's the brain is an anatomical structure. But on top of that, the brain, there is a mind there that thinks, that has got the emotion, that has got the feelings, yeah? That you can never measure through the CT scan or the MRI, all that thing. Okay, there is a lesion in the brain, okay, there is a cancer in the brain, there is a stroke in the brain, there is a this thing or blah, blah, blah in the brain. But in the mind, the emotion, the feelings, the emotion are hard, the feelings are hard, they have got the bad trauma, all that thing.
Which you can't see.
You can't see. And that mind controls the whole body.
Correct.
Yeah, how your heart is racing, how you are breathing, all that thing. So that's why, that's mind, the mental health plays a vital role. Yep.
So it's a main what do we call, a director of your whole body, or the main person who tells your body or your general well-being how it will be? That's why it's important to talk about it?
Definitely, because everything, every aspect of our body is connected to the mind. It's connected to the brain, but really speaking to the mind as well. So I don't want to make a disconnection between mind and body, because there's a lot of this debate has been going on for the long run. That's why there is a difference between psychiatrists and the neurologist.
Correct.
Yeah, there is a very distinction. As soon as previously Parkinson's disease was a disease of the mind, psychiatrists used to deal with that. And then they were able to find something organic.
Yes.
Then that Parkinson went from the
neurological
from the mental health to the neurology.
Correct.
Yeah. Physical symptoms, heart rate, breathing, even the simple thing. If you think about the pain, suppose I have got the wound here or the fracture here. The way amount of pain I perceive and the way you perceive, it's different. Pain threshold is different. Why? Why, suppose that person with the similar back pain goes to that level that they can't work, with the same amount of injury, the other person is able to function, able to work. Why? Because, truly speaking, we can't make a mind-body distinction. In this one, both the mind and the brain comes to the play. What happens? We have to look at the pain pathway. The pain goes spinal cord, limbic system, and then to the prefrontal cortex, where all the, so mainly the sensory center, all that thing, and then we feel the pain. Now, when that pain pathway goes, it crosses the limbic system, and what the limbic system does in our brain, it controls the emotion, it has got the memories, all that thing. So depending on the person, his level of emotion, his past memories, all that thing, that determines even the same amount of pain, how much pain that person is going to perceive.
Yep.
It's not that the person is faking it or making a voluntary that I'm having a severe pain. They're actually having a pain, severe pain, because that crosses the limbic pathway, which is basically has got lots of emotion, past memories, all that thing. So truly speaking, the mental health does cover like almost everything of our life.
Correct. Yeah. When we are talking about pain, they said pain is very, very subjective. And I'm like, why it's subjective? But it is subjective when you described just now. Like it can be for someone a very, very severe pain. Someone might say, oh, no, that's fine. So can be very subjective, isn't it?
So that's why when you look at the chronic pain team here, the pain team has got their own pain psychiatrist, pain specialized psychiatrist, or the pain psychologist. Because of this subjective, crossing the limbic system, and all this emotion, the feelings, the memories, controlling the amount of pain they have.
Correct. Sure. And the other thing, doctor, even I had this question when I was thinking to invite you in this podcast. What is the difference between psychiatrist and psychologist? Is this two people it's same, or what makes them different?
Now, psychiatrist is a medical doctor. Now, for the person to be a medical doctor, psychiatrist is a medical doctor, but psychologist is not. Yeah, some of the psychologists write the doctor because they have done the PhD.
Correct.
Yeah, but that's not the medical doctor. For this to become a psychiatrist, a person has to complete the MBBS.
Correct.
And then has to do all this training like a master's fellowship to become a psychiatrist, and they can prescribe. But psychologist is the one who does the therapy, like a talking therapy. They can't prescribe.
So they are more of therapist.
Even to become a psychologist, usually what they do is after they complete HHA or something in Australia, they have to do, I'm not 100% sure, but vaguely I know, like it's around 5 or 6 years degree they have to do that. And then once they complete, then they have to complete the master to become a clinical psychologist or something. And then they can become a therapist. Now, even within the psychologist, people do confuse with the counselor and the psychologist. Now, the counselor are the people who have done a bit of a training. I don't know amount of duration they take, but it's like a small training they do, and then they become a counselor. But the psychologist is the one who have properly studied the psychology for 5-6 years, and then they have done the masters before they become eligible to practice as a psychologist.
Sure. So basically, first, any patients who is going through some kind of mental health issue, they should go to the psychologist, and the next step is psychiatrist. Is that how it works?
It doesn't work like that. If the person has got the mental health issues, the number one in Australia to approach is a GP.
Correct.
Yeah. Now the GP determines the whether the person needs a psychiatrist or psychologist, or whether they can manage. Now, if suppose let's look at the depression. If the person is suffering from depression, if the person has got the mild to moderate level of depression, then even the psychological intervention alone can help. Yeah. So they have the cognitive behavioral therapy, which is the evidence-based therapy for the depression through the psychologist. So the GP can make a mental health care plan. Under that care plan, go and see a psychologist. Yeah, but if the depression is severe, then the psychological therapy alone won't be helpful. And then they have to see a psychiatrist who has to start like the medication plus the psychology. Now, if the person has got the psychosis, suppose it's hearing voices, is having severe paranoid delusion, all that thing, in that situation, referring to the psychologist is of no benefit, because they can't differentiate what is real, what is unreal. So in that case, psychology input is most of the time is not useful. At that time, the person has to be referred to a psychiatrist. In psychosis, yes, CBT does help with some hallucination, but compared to the depression, it's very less.
Correct.
So the number one step to approach is a GP, and GP are trained.
Correct.
Yep, they have done all this MBBS degree, fellowship degree, they know. And if they can manage, they will manage. If not, then depending on the mental health need of the person, will be referred to a psychologist or a psychiatrist.
So, doctor, I know you said GP is the first person to go here, but how that person will know even to go to the GP, like what's happening with me? I don't know. I'm not educated. I have no knowledge about mental health. How I know or how to self-diagnose first if I'm going through some mental health issue? What are the basic signs where we can, or symptoms where we find out, oh, okay, maybe something is wrong with me?
Now, what I would say is, please, to all the listener and all that thing, please do not self-diagnose.
Yeah.
Yeah,
When to go to GP doctor first?
Please do not go through a Dr. Google. Yeah, there are lots of different websites, lots of these TikTok videos, all that thing, and then all misinformation.
Which
Even if
we
you
do
have
a
to
lot.
go,
Yeah.
if go through some official website like the Black Dog Institute website or the Better Health, which are the official websites.
Correct.
Yeah, and then when to go to the GP, it depends. Like, if that condition, the mental health condition, is affecting your everyday functioning, like your social functioning, your occupational functioning, then you seek help. So for every mental health condition, yeah, it is considered the disorder once it affects your everyday functioning. Even if you are feeling depressed, but you are able to function, you are doing a productive thing in the life, all that thing, yeah. So basically, what the person needs to do is, when to seek help is basically when it's affecting their everyday life.
Correct.
Yeah.
Very difficult, I know, to understand. When we say this person has a depression, or this person has even anxiety or bipolar, or that person is schizophrenic, or that person has schizophrenia, the GP will be able to direct, oh, okay, you go and see the psychologist or psychiatrist, or we need to go and tell them, hey doctor, I'm going through this, you give me a medication. So is that GP can do it, or again we have to go through the whole chain? How, like one individual, for example, I have some mental issue, I go to the GP, and how it works from that time?
So initially, now just take the case of the depression. Suppose a person, individual A, goes to the GP and says that, doctor, I think that I'm feeling depressed. Yeah, I feel sad all the time. I'm having a very poor sleep, all that thing. Yeah. In that case, GP determine what label of depression the person has. If it's mild to moderate, GP can make, okay, I think you need someone to talk to, like a talking therapy that will be beneficial for you. And they can make a mental health care plan, and through that, okay, see this psychologist or that. Yeah. But if it's severe, then GP can say, okay, I think you need a referral to the psychiatrist. Or if it's very severe to the point that there is a risk, like the person says, I'm feeling suicidal, I feel hopeless, worthless, I'm making a plan to how to commit suicide, to that point, I don't want to, but these thoughts, suicidal thoughts always come into my mind, then the GP may have to refer to the hospital directly for this mental health assessment. Even they have to call the ambulance at the practice. And if mild to moderate or something, GP can start the antidepressant themselves.
Oh, okay.
Yeah,
So
and they can try 1 or 2 antidepressants. The person is not benefiting. Now the GP think, okay, the person is a specialist input. Yeah. Now, if the person with the schizophrenia goes to the GP having all this hallucination,
correct.
yeah, all that thing, and the person is already diagnosed, it's on some medication, but that medication is not helping. In that case, GP has to send to the psychiatrist, so that he needs a psychiatrist input for the further optimization of the medication. So that's how the GP determines. And the good thing in Australia is we have got different services as well, like we have got Head to Health. In the Head to Health, it's run by the peer support. That means the person who has had mental health issue
In the past?
in the past, but
Yeah.
now it's doing good
Correct.
with So they run that Head to Health.
Oh, wow.
So
Okay.
if you Google Head to Health, a lot of places have. Yeah, and that's one of the good resource. The person can make a self. If the person has got the issue with the mental health, if it's a child and adolescent, then they can call the Headspace, make the self referral, or they can call the Lifeline. Or if you are sitting at home and you are feeling like really bad, you are feeling suicidal, you can call the mental health hotline. And on the other side of the phone, it will be the mental health trained professional, either the nurse or the psychologist or someone who can guide you. So the number is 1-800 011 511. Call that number. It's a 1-800 number, and speak with someone. Okay, someone at the other side of the phone. Okay, I'm feeling really bad. I feel I'm feeling depressed. I'm not feeling suicidal, but I think I need help. I don't know what to do. The other person will guide you.
And they are medical professional.
They are the mental health professional. It will be either the psychologist or the mental health nurse. So they can call the mental health hotline. So there are a lot of resources there.
Wow, the amount of support we have in Australia, which is very big, isn't it, doctor?
Yeah.
In terms of mental health. Even so, we hear now and then news coming like this person has committed suicide. This been very bad incident, even household related, or even within the young kids. They are going through a lot of mental health issues, things like that. So the question I wanted to ask is, what do you think, like in young generation, or even like the people who has come from Asian country, immigrants, they have that stigma and they don't go and seek for help, even though there are so many resources available? Or what makes living in this developed country with all the resources, but still there is so many crime happening related to mental health? Also, the domestic violence happens. Why it happens? Because of people are a little bit scared that social stigma is going to be there, or what do you think, doctor?
Now, especially with the immigrant population who comes here as a student, now they are under tremendous stress. Coming here, from that, in Nepal, they are under the protected umbrella under their parents.
Correct.
Neither they have to cook or care about the working or all that thing. Suddenly, from that thing, come to Australia, they have to study. On top of that, they have to earn money so that they can pay their fee. On top of that, they might have taken the loan while coming here. They have to
Correct.
pay that money there. On top of that, they have to look for their accommodation, where to live, all that stress there. So, in the immigrant population who comes here for the study, the mental health is far more worse.
Have you
Because they have.
experienced any, doctor?
I've got a lot of patients in my private practice, the Nepalese student.
Oh, okay.
And the other thing is, the problem with them is they don't have a Medicare. That means whatever service I have said, most of them are eligible for the person with the Medicare there. Yep. If they go to the hospital, if they're admitted voluntarily, then they have to pay. Yeah.
Oh, okay.
And if they see a private psychiatrist, then they have to pay. Like for me, what I do is most of my Nepalese student I see, I charge them less.
Correct.
Yeah,
correct.
because that's one of the big stress there as well.
Finance.
Yeah.
Yeah.
And the financial issue, plus every day, they are struggling every day, like for their day-to-day life, plus support paying the loan, plus all that thing, the financial stress there, plus the academic stress there, the work stress there. Yeah. And the financial issue, that's one of the thing that's putting them
Not to go
not
and
to
see
go and
any
seek help. The
specialist.
secondly, they are not under the Medicare, so every medication they buy is not under the PBS. It will be expensive for them. Yeah. And then definitely the stigma there.
Yeah.
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 That's why the suicide has increased now within the Nepalese student.
Correct.
Yeah, the Nepalese in Australia here. Because they, and the other thing what I have seen is the illicit substance use, the drug use, that has increased as well.
Wow.
Yeah, and the gambling, the pokies, that has increased a lot as well
Yeah.
among the student population here.
I mean, that's something in a broader perspective, the gambling and pokies. That's something I guess it comes from they following the other people, the brothers who've been here before, and then you go and do it one day for fun, and second day you go with the other friend, and then third and fourth day, okay, it becomes a habit. How, as a parents who are in Nepal but they are not in touch with their kids, young kids, how they can support them, or what are the things the parents should be aware to at least prevent this kind of incidents, doctor?
Now,
Was there anything family member can do on this?
now from Nepal, it's very hard because they are sitting there all overseas, and the son or the daughter is here.
Correct.
Yeah, but the family, if they notice that suddenly there is a change in behavior, like the son who used to call me every day or every couple of days hasn't called me for more than a week there. Yeah, then something is going on there.
Correct.
Yeah, so and suddenly if they are repeatedly asking for money or the financial help, like this, that, look at the red flags, the warning signs. Now, how they can help? They are sitting in Nepal. Now, the students here is in Australia. It's very hard, but maybe having a regular chat over the video link, being a more supportive, yeah, and then not to put a lot of pressure on the kid or the student who comes here, like Babu, like we have this much amount of loan, this much amount, this, we are going through all that thing. They're already under stress. On top of that, the parents are giving the stress from Nepal. They are basically burdening the student. Will make them further depressed there.
Correct.
So, truly speaking, it's hard for the parents how to support or monitor from Nepal here, but not giving the extra pressure or extra burden, yeah, to the student who is studying here, working here, dealing with the everyday problem here. That's the one way they can provide the support.
Yeah, as you said, there's nothing much they can do, but whoever is here around their friend circle, or if they have even the relatives, maybe asking them to check on them. Because recently there was one incident where the very young Nepali guy was found dead somewhere in river within NSW, which was very sad. I mean, when you think about it, they come in such a young age. As you said, they don't have any responsibility back in Nepal. They don't need to cook. They don't need to earn. They are kind of a spoiled kid. We all been through that journey. But when you come all of a sudden in different country, there is not a lot of social support or emotional support. I think as a parents who are back in Nepal, they do have some degree of responsibility to...
But a good thing these days is there are a lot of Nepalese in Australia who has come here. So most of them, not all of them, most of them have someone here in Australia. Like initially when I came here, I was alone, right? Me and my wife came here. There was no support. We knew nobody here in Australia. But after we came, like my niece came, my nephew came, my brother-in-law came, all that came, and they are settled now. But when they initially came, they had our support. Yeah. So what I see in Australia is nowadays a lot of the students who are coming, they have someone here, some family member here. So maybe the family from Nepal asking them to keep a close eye on them or extra family support. That's the way that family could provide a support.
Yeah, correct. Doctor, we were talking about the social stigma before. Do you think social stigma affects the diagnosis, especially when we're talking about the Nepali community in here, or even back in Nepal, or even in Western country where you are practicing your medical professional?
Yeah, look, that there was a big research conducted in Japan. What they did was they changed the name of the diagnosis schizophrenia. So they changed the name of schizophrenia to the completely different name so that that stigma is not there. Like when you have a schizophrenia there is a label there. You are a schizophrenic or you're this, that. Yeah. So in Japan, what they did was they did this research. What they found is that, truly speaking, there is not much of a difference, but there is a big difference in the patient compliance with the medication, and then the doctor and the patient relationship was much improved.
By just changing that name.
That label, that diagnosis.
So that means do play the big role. This
Yes.
stigma does plays the big role.
Yes, definitely, the label.
What can we do, doctor? I mean, as an individual or even a medical professional,
Yeah.
how do you guys think can make a difference in this? How to work on this? Because it's like a constantly going through the same, and then people come, oh, I don't want to open about it. What if they will call me a drama queen? Or what if they, oh, this lady is crazy? So how can we make a difference on this?
Now, basically, not. It's basically like in terms of the stigma, there are many like the first one is a self stigma, in which the person who is struggling to the mental health, they feel that they are inferior to the other people. They are weaker than the other people. That thing needs to be within the self. The first thing within the self that needs to be dealt with. Like, okay, I'm dealing with depression. Okay, I have got the bipolar. Yeah, people have got this diabetes. People have got this hypertension.
Correct. Take it
It's
in
a
that way.
disease. Yeah.
Yep.
And
Yep.
I'm taking medicine, and it's a treatable mental health. It's a treatable condition. Yeah. So that self, and plus the people are going to think me weak. People are going to treat me in a complete different way. So that's a perceived stigma that,
Correct.
okay, this person is going to treat me. That within the even within the mental health, the patient, they have to change within themselves.
Which happens a lot, doctor. Even in
Yeah.
day-to-day life, nothing related to mental health. If I have some kind of weakness, I feel like, oh, they will judge me. I better make myself look smart or intelligent. I know everything. Otherwise, these people will going to judge me. That we do anyway.
And the other one is the social stigma. Uh, Most of the time, there is a common perception in the society is that the people with the mental health issue, okay, they are weaker. Either they
Correct.
need help or they need the support. They need someone to look after them. That thing, why? The people with mental health issue can, depending on the level of severity, right? Why they have got the disease, but they are able to function with the medication, all that thing. And plus, the other thing is, okay, this person has got the bipolar, this person has schizophrenia, this person is going to be violent. There are a lot of crimes happening. All this is that they can kill anyone. All that thing, no. Truly speaking, the person with the association of the violence with mental, who are actually mentally unwell, they are not a violent person. No.
Okay.
So, truly speaking, that all this perception, all that thing needs to be changed. So, when you are sitting with someone with a mental health issue, the person who having a depression, till that treat them as the way you are treating the other friend. So it's a same person there. They just have got the disease there.
Yeah. Yeah. It's like having a diabetics or something.
Yeah.
Physical.
Okay, so I have got a friend who has got the diabetes here. I have got a friend who has got the depression here. Both are my friends.
Yeah, start treating them as equal rather
Yeah.
than giving that tag. Oh,
Yes.
this is mental health. Yeah, but I know we say that we need to start, but then especially when we talk about the Nepali community, I think doctor is going to take a lot of time to have that change in thinking or perception towards anyone who has gone through the mental health. Especially in rural or even in villages, you can see if someone is going through. I was watching one documentary the other day, and it was so sad story. One female had some mental health issue, and they have literally locked up her with a little chain, and then they will give her a food and everything, and she's kind of sitting outside. They have made little kind of cottage where she was living there, and they will go food and everything there, and she was bound with a chain, which was very sad to say. But lucky the people who are in overseas, they have got some kind of idea how it works. And I think it's high time we all have to work, even as an individual, to make that change and make people understand how it works. And it's equally important like the physical health, isn't it?
And just like recently, I have seen this Korean drama. It's in the Netflix, and I would advise everybody to watch it.
Okay, which
So
one?
that one is called the My Little Sunshine.
My Little Sunshine,
Yeah.
sure.
So it's about the mental health issue. It's a mental health nurse who actually goes into the depression, severe depression. Yeah, and then She is actually locked up in the mental health unit. After that, how she deals with her self-stigma, her perceived stigma, and the social stigma to get her back into the life, the way they have portrayed the stigma in that whole series, around 12 episodes, superb.
I'll definitely watch that,
Yeah.
doctor.
The mental health nurse who knows about the mental health, who knows about the stigma, how she went through her journey of recovery, they have portrayed it so well. That drama there.
I had one question, doctor. It's around impact of environmental and lifestyle, or how factors like past trauma, stress, or social support, even the daily diet or exercise impacts in our mental health. Is there any connection?
Now, look, in terms of the management of mental health, the management depends on the 4 pillars. Yeah, the medication is not only the answer. The people think we don't have a magic pill here. We don't have a happy pill. Yeah, like you give a magic pill and the other person depression is gone there.
No.
So the management depends on 4 different pillars.
Correct.
One pillar is a medicine.
Okay.
Yeah, definitely. Yeah, depending on what medication needs, what are the proper antidepressant or mood stabilizer, antipsychotic or whatever the person needs, depending on the mental health. That occupies one pillar.
Just one part covers the medication. Correct.
3 pillars are, other one is a psychology, the way they think, way they feel, way they behave. That plays a great role there.
Correct.
Yeah. And on that one, on the psychological therapy, so basically, when the person is depressed, what the psychologist does is they basically do cognitive behavioral therapy. What is a cognitive behavioral therapy? The cognition. That's the person's thought, the way they think. Like, I'm a failure. I'm weak. I can't do anything. So that's a cognition there. Now, how to change that cognition? That's how the CBT works. Yeah? The person who's a chronic self-harmer, or a person who has got the rapid fluctuation of mood, like currently the person is completely fine, suddenly become sad.
Yeah.
Like
crying.
100 to 0, all that thing. Yeah?
Yeah.
Now, for that thing, there is a lot of emotional dysregulation there. So that person needs a different kind of therapy, dialectic behavioral therapy, which runs in the 4 different components. Like, number one is emotional regulation, how to regulate the emotion. Number second is distress tolerance. If some distress happens, then how to tolerate that. Mindfulness, and then the interpersonal skill, how to improve the interpersonal skill. So that person is a DBT. If a person has been through a trauma, like significant trauma in the past,
Correct.
like a rape or something, or sexual assault or something,
Yeah.
now they need a trauma-focused therapy.
Wow. So
They did the, in the trauma-focused therapy, 2 are the evidence-based. One is a trauma-focused CBT. The other one is EMDR, this eye movement desensitization. So these are the different therapy, depending on the mental health of the person, and that occupies another 25% of that
Okay.
person there.
Yep. Yep.
Then another 25% is a social support. Now, suppose if the person is going bankruptcy, or the wife has left, or something, when the main stressor is there is no social support there. Whatever we do, the medication, we do the psychology, the main stress is still there. And that's why in the hospital we go for holistic management. If the person comes, we involve psychiatrists as me for the medication, psychologist there, and the social worker there,
Yep.
who tries to, like, we can't 100% mitigate or remove the person's stressor, but we try our best. If the accommodation issue, try to find some accommodation. If central link is the issue, then social worker to deal with the central link. Or if the relationship issue is happening between husband and wife, then the relationship counselor. We look at the social thing, because we have to look at the not only medication, secondly the psychological. Now we have to look at the social thing.
Correct.
Because unless the social thing is not sorted, medicine and psychology, they are just playing 25% of the role
Wow.
there.
It's a holistic approach.
And then the final pillar is a lifestyle. Now, whatever we do, the person if is abusing this ice or the cocaine, all that thing, or drinking every day, the medication will not be beneficial, or the psychological will not be beneficial. They have to change their lifestyle. And for that, we have to look what we can do for that person to change that lifestyle. Like, okay, the person has got the alcohol problem. Then linking with the drug and alcohol services. Or the person doesn't want to quit. Then giving a motivational interview. This is the technique. Giving a motivational interview so that the person from the not wanting to drink, try to bring them to, okay, I'll think about drink.
Yeah.
Then to the next step, okay, I will try to quit. Yeah, and plus we have to bring some balance, like the structure in the routine, waking up, sleeping, exercise, all that thing. So for the proper management of mental health, medicine is not the 100%. It's just one pillar there. The other pillar is the psychological, the way they think, the emotion they have, the feeling they have, how to do that, and they need a proper therapy. Yeah? And then social, all this social balance, and finally the lifestyle. If these four pillars are balanced, then that's the way the mental health is managed. And when I see a patient, I look at all these four different perspectives in the management.
So it takes a lot, but then having right channel in the correct space, not only the medication or not only the doctors or psychologists or psychiatrists will be able to help. It's a holistic approach we need to go through. Doctor, okay, that's the one part. But as a patient, for example, me, I'm going through some issues where I can't be happy. I'm feeling sad all the time. I don't have energy to wake up and do my daily things. And nothing makes me happy. So in that case, going through some kind of therapy or communication or having just a communication help, how it changed? I just wanted
Now,
to
suppose the
know.
symptom that you have said me, and you go to the doctor there.
Correct.
Number one thing, always think about whether there is any medical cause happening there. Yeah, recently I had a patient, like it was a Nepali, like a very senior member of, much more senior than me, the Nepalese community here in Australia. He called me and
Correct.
said that his brother was going through the very, like this, mentally unwell, hearing voices, seeing things, and then aggressive, all that thing, what to do. And I said, okay, in that case, the first thing, please take the GP and get at least the first blood test done. Once the blood test is done, I booked the appointment in a couple of days in my private clinic
Correct.
for him. And went to the GP, they did the blood test. His sugar was high above.
Hi.
Yeah.
Even diabetes can play the
Immediately, ambulance was called. He was taken to the hospital. He was admitted in ICU. His sugar was brought into the control. Hallucination, everything was gone.
So that the high sugar was causing that.
That sugar was making the person delirious. Person went to the delirium, where the person was hearing voices, seeing things, acting completely bizarre. I had an appointment a couple of days. The patient didn't come, and I called that brother, who is a very senior member of Nepalese community here, and said, "What's happening?" I was expecting him to come, and he said, "Well, you asked me to do the blood test. Went to the GP. The sugar came this much. Was immediately taken to the hospital. Was admitted in ICU. Now completely fine."
So that means, doctor, sometimes
always try to rule out medical cause first. Like symptom you told me, I'm feeling bored, I don't have a motivation, go to the GP, do the blood test. There are lots of medical causes which can cause the depression. Like number one, thyroid function. If you have got the hypothyroidism, that can cause the depression. If you have got hyperthyroidism, that can cause the mania, psychosis, all that thing.
Oh, really?
You have got the other different medical condition that can cause the depression. Plus, even the medication, like suppose if you are on the blood pressure medicine like beta blocker or something, that can cause the mental health issue as well. Even there are a lot of medication that can lead to the depression or psychosis. If you are on the steroid, suppose, for a long run, the steroid can cause the psychosis itself. It can cause the depression itself. So, the symptom that you told me, the first thing is always try to rule out the medical cause first. Once the medical cause is ruled out, the symptom that you told me, the GP or the doctor will do the further assessment. Why? Once the medical causes, everything is ruled out, then okay, I have to assess what level of severity of depression you have. Number second, whether that's a depression alone or the depression is with some other symptom like anxiety, or that depression is a part of a bipolar or part of the... And then I have to look whether that depression is due to the social stressor, or is it the reactive? Like suppose a person is having going through the divorce, then their person is having a depression. Or suppose a person has got to break up with the girlfriend, that person is having a depression, suddenly again patch up with the girlfriend, depression is gone.
Yeah.
So we call that more of an adjustment disorder. So basically we have to determine what's happening there, what is the stressor leading to that one, and depending on that we have to make that holistic plan, whether If it's adjustment disorder, like a breakup with the girlfriend and the person is feeling very suicidal, getting admitted, if I start the antidepressant, that's not going to be helpful. Because that's a reactive, that's a secondary to the stress there.
Correct. Correct.
Yeah, so determining all that thing, looking at why it's happening, and then go for that holistic 4-pillar management in that person there.
And that's how you as a psychiatrist treat your patient.
Yes.
You have to meet through that 4-pillar, as you said before.
Yeah.
Go through that. And then, as you said, like in our country, having that family member or family support helps a lot, which now makes sense,
Yeah.
isn't it? Having that family support when you're going through stressful time or breakup, financial bankruptcy or whatever, having someone there from your family helps.
Yeah.
Makes sense, but very complicated to understand, like how the mental health can come from different physical reasons, not only being solely mentally only, isn't it, doctor? Yeah. When I was doing some kind of research, doctor, when I thought you are coming and I have to prepare myself, I come across with one particular terminology, not terminology, the concept, crisis intervention and suicide prevention. And I'm thinking, why they are calling it a crisis intervention? What is this? Do you, like, tell me about it, doctor. When we say crisis intervention, what it includes, or how you guys practice in your profession?
Now, basically, when you look at the suicide, right? If you look at the definition of the suicide, a lot of the people, dictionary have put the different, to kill themselves, blah, 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 blah. But what I believe is that the suicide is something that the person is going through some stress, some problem, and they are not finding any better solution apart from the suicide. They don't want to commit suicide. There is ambivalence there.
Yeah.
The person who is actually committed suicide, attempted suicide, they don't want to commit suicide, but they don't have the answer to their problem apart from suicide.
Yeah.
Yeah. So basically, in the crisis intervention, what we do is we look at that ambivalence there. Yeah, because there is ambivalence there. They don't want to commit suicide, but they are not finding any solution to the problem.
Correct. Correct.
Yeah, apart from the suicide there. So, how to deal with that problem there? Now, in the crisis intervention, what we do is basically look at what does the patient needs.
What is the actual problem?
What is the actual problem there? How we can help. Yeah. Now, suppose a person has a breakup with the wife. Person has got the big fight with the wife, or the wife has a big fight with the husband, goes there, took the overdose, ambulance call, brought in the hospital. Yeah. Then the person might need some days of the crisis admission, because they might still be feeling suicidal. They might all that thing. So couple of days admission so that they could calm down. We are not starting any medication. We are just admitting for the patient to calm down.
Okay.
That's one of the crisis intervention there. Yeah. And the other one is, in the community, if the person is feeling suicidal or feeling depressed, maybe they need someone to visit, someone to talk to. Then we can refer to a psychologist. And in terms of the psychologist, if they go to the GP and ask that please refer to the psychologist for suicide prevention, if GP mentioned that word suicide prevention and mental health care plan as ATAP suicide prevention, referral, they will get appointment very soon.
Okay.
With the psychologist. Yeah. And yeah, in the community, someone like community mental health team will do the follow-up, will check how the patient is going, what are their needs. If they need a psychiatrist appointment, they book the appointment with the psychiatrist. Yeah. So these are the main crisis intervention. Plus, if they need a social worker, then involve the social worker. So basically, we are looking at that 4 pillar there in the crisis intervention.
Doctor, in many cases, the person looks very happy. Everything is working well in his or her life. And then next day, we hear the news that person committed suicide. For example, I think not long ago, 6 or 7 months ago, we had a very, they doing good in the career, a model plus actor from Nepal, a very young age. He looked perfectly fine around his circles or friends, they are saying. But then he committed suicide. As a friend or as a colleague, how do we know if that person is going through that thoughts? Is there any clues or sign and symptom they saw that where we can pick up and offer a help? Or is there any way we can find that? Because they look normally fine, everything is okay, but then next day they commit suicide. So what are the signs and symptoms as a colleague or friend or even a family member we should look at?
Now, look, basically, in terms of the suicide, only mental health reason is not only the reason for the suicide, right?
Yeah, yeah.
Though it's called that it's all because of the mental health, it's hard to say it's all because of the mental
every
health.
time if someone
But
commits,
most of the time, it's due to the mental health reason.
correct.
Yeah. And the research that was done in Australia had shown that the person who has actually committed suicide, more than 80% of the population has actually tried to seek help. Like they have either called the mental health hotline or presented the hospital within, I think, a month or something. I forgot that research.
Correct.
Yeah, so they have actually tried to seek help. So mental health is one of the reasons, but not almost every reason. Like one of the very old sociologist called the Durkheim, he has made the 4 different types of suicide, like egoistic suicide, fatalistic suicide, anomic suicide, all different category.
Correct.
So in that, like one of the suicide was altruistic suicide. That's like suicide is a pride. Who do the suicide bombing?
Correct.
For them, they are doing the suicide, but it's a pride there. It's not due to the mental health reason.
No.
Like in Second World War, kamikaze warrior, like when the Japanese fighter plane in the American, all that, they used to go and dive so that ship can blast.
Correct.
That's a pride. Yeah, so that's altruistic suicide.
Yeah.
The other one is the anomic suicide, like sudden disbalance, like the person who is the very rich suddenly go bankrupt. So suicide, there are different reasons. It's not only mental health, but mental health is one of the prime reason for the suicide. Yeah. Now, if it's because of the mental health, with that actor in Nepal, yeah, the family must have noticed something. Like the person might have showed differently outside, but internally the family must have noticed some change in behavior there, some change in sleeping pattern there, some change in mood there, some change in eating habits there, something. So if anything, a red flag or red alarm happens, then family should have spoke, are you okay? That's why we have Are You Okay Day in Australia.
Correct.
Yeah, just to ask, are you okay? What's happening? More open communication. Yeah, and most of the time, suicide happens impulsively as well. The person is completely fine.
Correct.
Yeah, and suddenly some news comes, something comes from out of nowhere, and the person impulsively
Makes that decision.
and it's hard to predict on that one. So I don't know about that actor, like who was she or how did she commit suicide or other thing. If it was due to the mental health reason, then she must have shown some symptoms, some signs, some red flag to the family. Yeah, which the family may have, family should have picked up, or at least ask, or the friends, are you okay?
You didn't mention twice red flag. When you say red flags, what it includes?
Red flags is change in behavior. Like
Correct.
suppose the person who likes talking to the people or likes watching movies suddenly is completely isolated, not talking to anyone, or suddenly the person is not sleeping at night or excessively sleeping 15, 16 hours a day, or the personality had changed there, or so these are basically the red flags. Like sudden change in the behavior, or gradual change in the behavior, or the pattern, or the communication.
So it makes a big difference around surrounding people to know and then go and ask, are you okay?
Yes.
Yeah. Other thing, doctor, it comes a lot when we speak about mental health. Self-care is important, well-being is important, we say a lot. But how to implement that self-care in life? What are the things we should be doing? Not major things like going and seeking help and having a personal trainer in life. Not everyone can afford it. But what are the things we can do in day-to-day life to look after ourselves in terms of mental health?
So
Any
I think
tips as a
on
psychiatrist?
that one, if you go through that Korean drama,
My Little Sunshine?
Yeah.
Correct.
My Little Sunshine or My 100 Sunshine, just it's something with the sunshine there, that Korean
Correct.
drama. That one has got so the very good, the way it has portrayed or shown in that drama is really good. So nowadays, the trend in the self-care or the psychology
Yep.
is going more towards the positive psychology there. A lot of the thing we do, like cognitive behavioral therapy, dialectic behavioral therapy, trauma focused therapy, basically we are looking at what is wrong with that person and how to change that wrong to more right, right? The way of thinking, what is the thinking pattern, what I am failure, all that thing, that's a maladaptive thinking, or the poor cognition there, negative cognition there, how to change into more positive.
Correct.
But nowadays, a trend is coming as a positive psychology. That means every person has got something positive there, something good there. Rather than focusing completely on the negative, increase that positivity in that person there.
Does someone need to
Yeah.
come and tell that to that person, or it can come within
So
yourself?
with the positive psychology, what you do is the basically number one is compliment yourself. Yeah. So one of the thing is a compliment diary. Make a diary, and every day you compliment yourself. Okay, 5 things I did good today. Yeah.
Yeah.
Thank yourself. Compliment yourself. Yeah. The other one is increase your social. So there is a technique, step involved in the
Let's go
positive
through this
psychology.
step, doctor, so that our
Not on
viewers-
top of my head at the moment.
Okay, no, that's okay, but
Yeah.
at least few steps which we can implement in our
Yeah.
day-to-day life.
So one is this, the
Complimenting yourself.
diary.
Thanking yourself.
Thinking yourself.
Yeah.
The way they have portrayed in that Korean drama was really good.
Okay.
And currently, in the psychologists, American Psychologists Association, the current chairman who got elected, his first speech was, let's focus this psychological trend now into the more positive psychology.
Yeah, yeah. It's very
And
difficult
then
to...
other
yeah.
one is compliment diary. The other one is a me time. Me time, what happens is,
Yeah.
like you work all day, come home, kids, yeah, all that thing. Where is the time for you,
For yourself.
yourself? So maybe in a day, half an hour, 1 hour, this is my time, me time. If there is a kids there, husband there, boyfriend there, blah, this is me time, nobody's going to disturb me.
Oh, wow.
Yeah.
Okay.
And that in me time, you do what you like. Maybe half an hour a day. That's my time, my space. Yeah. That's one of the thing that will help as well for that
So
person.
what do we do in that time? Go and scroll down to TikTok, or we stay in Instagram?
What do you like? What do you enjoy?
Okay.
Some person likes to read books, or some people likes to dance, or some people like. What do you like?
And that's very important, doctor, to do
Yes.
that?
One person has to have their own me time, at least half an hour or an hour a day.
There's some people, they do hashtag in Instagram when you go and see, and they're writing, it's me time, and they have gone for a manicure or pedicure, which does make sense, isn't it? Because
Yeah.
that's what you like to do, so do it. Yeah. What are the other things, doctor? Positivity in day-to-day life. Think positive about yourself.
Yeah.
Yeah. I had one friend in uni. She's from Nepal as well. And she struggled a lot with her OCD, doctor. And before that, to be honest, I come from Nepal and I never had that kind of education around mental health. I've done master's degree in sociology, which is more focused on social evaluation, how the society becomes marriage, things like that. I've never heard about OCD. And that's the first time I heard, what is OCD? And I'm like, no, it does not make any sense. Some people going through the OCD. And then when I read about more, and then seeing that my friend and very, very close friend, and I could not help her, did not help her, didn't know how to help her. But now, since I have done a little bit research, and then it makes, oh wow, I could have done more. So someone who's going through that situation, doctor, someone is there, the family is, the friend is asking for help, but does not know how to help. What are the very basic thing as a person you can do to support someone who's going through mental health, who's going through OCD in their life, who is going through depression or even sad phase in their life? What are the very simple thing without costing any money we can do?
Now, the first thing about the OCD, what is OCD? Yeah, it has got the two parts, obsession and compulsion there.
Correct.
Now, when you say obsession, it's DSM, which is the main Bible for all these diagnostic criteria.
Correct.
The obsession, that's the persistent, repetitive, ego dystonic, leading to the anxiety. So 4 components there,
Yeah.
leading to compulsive behavior there.
Yeah.
So that means persistent. It's coming persistent, recurrently, repeatedly. Ego dystonic means they know it's wrong. Like suppose a person who keeps on washing the hand, my hands are dirty. They know I don't need to wash the hand, but they can't control. It's ego dystonic, against their ego.
Oh, yeah.
Yeah.
Exactly same.
And then it leads to some compulsion.
Correct.
Yeah, and the compulsive behavior, washing hand, to the point that they have got all these rashes.
Yeah.
So now the OCD, what we can do is,
How can we help?
number one, look, in terms of the being a psychiatrist, I start with the medication, antidepressant.
So the person who's going through the OCD, doctor, they have to go through the medication?
Most of them have to.
Okay.
The OCD.
And does it helps completely to prevent or cure?
It's curable, totally curable. There are steps there. And the antidepressant, not all antidepressant, there are few antidepressant which are specific for the OCD there. Yeah. And then usually the antidepressant dose is higher than the normal dose
Okay.
in the OCD. Like if you are prescribing, suppose the fluoxetine 20 milligram for the person with the depression or the anxiety in the OCD, I might have to go up to 60.
Oh, okay.
And if it doesn't help, then we have got these steps in the medication, like the antidepressant, like sertraline or fluoxetine or whatever. Doesn't help, then go clomipramine, then all that's fluvoxamine. If it doesn't help, then augment with antipsychotic. Like they're all patterned there. There is a whole guidelines how to augment the medicine. Now, in terms of the psychology, the OCD, what the best evidence-based therapy is the exposure and response prevention.
What does that mean?
In the exposure and response prevention is basically they are exposed to the situation where they have got the obsession.
Yeah.
Now, suppose the person has got the obsession regarding the germs. My hands are dirty, all that
that's
thing.
very common.
And because of that, they can't go to the public toilet.
No.
Or they wash their hand 100 times a day. I had a patient who used to finish like 5 sanitizer a day, 5 bottles of sanitizer a day.
Yeah.
So on that one, basically first, it's completely up to the psychologist, but what usually the psychologist does is they make a such score, like the subjective unit of distress score, in which we rank, like suppose going to the public toilet, such score might be 90, that they
Not
to
able
that
to
level.
close the door, not able to...
The other one,
Yeah.
touching this one, might be subjective score of 5.
Correct.
Yeah?
Yeah.
Or after the toilet, that might be quite high. So depending on that, they make the subjective unit distress score and start from the low one, which is the lowest score there. Try to expose that. And the exposing is 2 different types. First, they start with in vivo exposure and then in vitro exposure. In vivo exposure is they make the person think, imagine, and then try to expose. In vitro is they actually take the person to the, like suppose psychologists accompany the patient to the public bathroom, try to make them flush. And then, so the exposure and response prevention, that's the main part of the therapy in terms of the psychological for the OCD. Now, what the family can do. What happens with the OCD is, if the person has got the OCD, they try to involve the family member in their OCD behavior.
Yes, correct.
Yeah, it's not only that they wash their hand, they make their family to wash their hand.
Correct.
Yeah, and so basically they are trying to involve the family in their OCD behavior. As a family, what they can do is, if the family completely oppose that, no, that's wrong, you are doing wrong, that's not going to be beneficial. That's going to increase the OCD there.
Okay, sure.
Or if the family goes what they say, okay, let's do.
Agree.
Yeah, agree. Even that's not, they are giving the positive reinforcement there.
Yeah.
Other one, negative reinforcement, here positive reinforcement. Now the balance approach has to be done.
Sure.
So what I do in my practice is most of the time involve the family. I even have this education, the family session, how the family should communicate with the person having the OCD. Yeah, and basically it's a balance approach.
Okay. So agree or do not agree then, doctor?
It's like explaining the real reason. Yeah, in the balance approach.
Don't
Rather
be
than
too
completely harsh, not completely supporting it.
harsh. Try to show them what is real.
Yes. And then now, anxiety. You said like, what are the practical things that we can do that can help the person without the
Correct.
costing the money? Now, anxiety is very common. Yeah.
Yeah.
Even in Australia, it's around like out of 100 people, 15 people have got the anxiety disorder. Yeah. And then, in terms of the anxiety, what they can do is the anxiety is basically it's a worry, right? Scare. Like if a person worries a lot, they are unable to control the worries, and these worries lead to the like feeling restless, feeling on the edge, muscles are being tense, having problem with the sleep.
Sweating.
Then they feel their heart is racing. Then all that thing. The main cause is worry there.
Yeah.
Yeah. Number one thing they can do is mindfulness, meditation. That will be helpful. Yeah.
Yeah. Meditation.
And the mindfulness is being mindful. Like the worries come, problem come, thoughts come. For every person, we can't. But let it come. Do not react. Let it pass through. Yeah.
Yeah.
Worries come for everybody. The problem will come. Everything will come. Don't try to resist it. Let it come. Let it pass through.
Yeah. Face it.
Face it.
Yeah.
And the one of the thing which I say to few of my patients is there is a very good mindfulness meditation class. It's a retreat that happens in Nantiang Temple.
Oh, yeah. Yeah.
So you have to go there, stay there for 2 days.
Uh-huh.
Yeah, and they give a very good teaching about this one, the mindfulness meditation. Otherwise, there are a lot of YouTube video as well
Correct.
for the mindful meditation. How you can do that? Like it's easy to say, like come, do not react, let it pass. But
Yeah.
how you are going to do
How
that?
you gonna actually
So there are a lot of
implement.
YouTube video as well.
Uh-huh.
And then the other thing that you can do is breathing exercise. Now, breathing exercise, you have to know proper, correct technique there. And there are a lot of YouTube video as well for that.
Yeah. Yeah.
There is another one called the progressive muscle relaxation. It's like relaxing every part of your body, and it's like 15-20 minutes every day, morning and evening. And how to do that? Again, YouTube video. The YouTube is a very good one. Like how you are gradually relaxing every part of your muscles, and especially the person who has got the problem with the sleep. If they are finding difficult to fall asleep, progressive muscle relaxation will help. Yeah. And then the other thing they can do is they can maintain like a diary, thought diary. Rather than keep on worrying here, you have put something down there. And the other thing, what I say to my, there are a lot of CBT techniques there. Yeah, like ABC analysis, all that thing there. One thing I would say will be beneficial for a lot of the people is maintaining a parking for the thought. Like you have the car park, yeah, car parking.
Yeah.
So in the car parking, you have got half P zone, 1P zone, 2P zone, all that thing.
Yeah.
Suppose you are worried about something, you keep on worrying, and if you try to find a solution at that time, it won't be rational because you keep on worrying all that thing if you can restless, yeah?
Yeah. And how to park that?
So what you do is, okay, you are having all this problem there. You maintain a diary. This is my thought parking, like a car parking.
Yeah.
In that, make a section there, like half P zone, 2P zone, 4P zone, all that thing, or 1 day parking there. What's the priority of that thought,
Okay.
that worry?
Yeah.
Put that in the diary. Put that on the, depending on the priority, whether that has to be dealt today or whether that can be dealt in the half P zone, 2P zone. Put the alarm in the phone. Yeah?
Yeah.
And then if the thought comes, no.
Don't think about it.
Because I have put that in the
Oh.
parking zone
okay.
there.
Yeah. Yeah.
So that problem is a parking zone. I will revisit it. I'm not going to ignore it. I'll revisit it, but
But
I'm
not
going
today.
to for 2 hours.
Correct.
It's in the parking zone.
Correct.
Yeah, and you have put the alarm, and then do something else.
And
And
the
after,
self-reassurance as
yeah,
well, isn't it,
after,
doctor?
and you make a rational decision as well, much more
Correct.
rational decision at that time. And when you make a decision, how you, it's a problem solving focus approach. Basically, what you
Correct.
do, problem, write the problem down. Don't try to solve here. You keep on thinking, it will write the problem. Then write the solution. What are the brainstorm the different solution you have? Yeah, like suppose some friend is not talking to me, or some friend got. What are the all the solution 4 5? Brainstorm for every solution. Write what are the pros, what are the cons, what are the pros, what are the cons. Then come to the correct solution, like the most beneficial one. So
It makes
this one,
sense.
these are all CBT technique. There are lots of different technique. One technique I have mentioned this about the car thought parking thing. Yeah, and there is another one like ABC analysis. Suppose you suddenly feel that you are feeling restless, or your heart is beating, or you have a panic attack. Then ABC analysis is antecedent. What happened before that?
Try
Yeah,
to find out the cause.
yeah.
Yep.
And then what happened and what was the consequence there? Write it down every time, and so that when next time when you go through that diary there, it's like a metacognition. That means all this cognition, your thought that happened, you are looking from again from the third perspective. Now why it's coming, why it's happening. So, whenever I have a fight with my husband, it happens. Oh, whenever kid does this one. Oh, whenever my friend says this one. So we know what's causing that problem, like ABC analysis, like maintaining the diary for that one. If you want, there are lots of app as well in the Apple, in the Samsung, all this Google Play, all that thing, the CBT apps there. There is a thought diary you can get in the apps nowadays.
That thought diary, I really liked it, doctor. I think I need to implement that.
Yeah, so there's a lots of apps there
Yeah.
nowadays, and even the CBT. If you really want to do, then there are lots of online CBT course there. Most of them you don't even have to pay.
Okay.
And if you want, then there is a book called the CBT for Dummies. In the Google, there it's for dummies. That means for the layman. Yeah, and that book it's in the PDF, completely free. Yeah, and that book has got basically 21 or 22 chapters, and that 21 22 chapters is exactly what the psychologist does in every session.
Wow.
Yeah,
Okay.
and it's written in complete layman, and that book has two parts. One is a theory part, the other one is a workbook, practical part. If you are going to the problem, get that book download printed from the Google, and do exactly what they are showing, what they are telling, so that you can control your anxiety, you can control your depression, even without paying money there.
Yeah.
Yeah, and there are lots of other online CBT classes, like Beyond Blue runs the online CBT, lots of online CBT there. You can do that. They are free. Most of them are free. Yeah.
To control anxiety, which happens
Anxiety and
a
the
lot.
depression as well.
Yeah, which happens a lot when you are working and then it's a busy day. There's thousands of things going. 8 hours day is not enough. I think I need to practice that, doctor.
Yeah. So get
Definitely.
that book printed, and that book has 22 chapters. Don't read all of them at the same time. Read one chapter at a time. Practice whatever they have said in that for a week, so that
Correct.
you can actually understand. Then next week, go to another chapter. So it will take about 22 weeks for you to complete. If you want to complete in the rush, at least do 2 chapters, so that in the 10 weeks is complete. But don't try to do a lot of chapters at the same time, because
It's going to be too
Yeah.
much. Okay, thank you, doctor. That's really informative.
so it's called the CBT for Dummies.
CBT for dummies.
Yeah. And that's a really good book for the layman.
Great. Thank you, doctor. We did cover a lot of things around mental health, doctor. Last week, I did posted one TikTok video where I said I'm going to have a psychiatrist on my podcast. And then if you have any question, please reach out. And I've got so many questions, but out of those, I thought 2 were a little bit important where we can discuss, because obviously we can't cover all the questions. I'm going to read it out. Of course, the requester has requested to keep their identity private, which is fine. I'm going to read it. It's from one of the sister, and she's currently living in Nepal. So what she has written, I'll read it out for you. Hello sis, I just saw your video regarding mental health. मलाई आजभोलि एकदमै नेगेटिभ थट्सहरू आउँछ. मेरो 2 वर्षको बेबी छ. उसलाई पनि इमेजिनेसनमा मसँग झगडा गर्दा पिरोल्दा एकदमै पनिसमेन्ट दिउँ जस्तो लाग्छ 2 वर्षको बच्चालाई. मलाई थाहा छ यस्तो गर्न हुँदैन, राम्रो कुरा होइन भन्ने नेगेटिभ हो भन्ने थाहा छ, तर पनि अटोमेटिकली आउँछ कि यति धेरै रिस उठ्छ कि बच्चालाई नै पनिसमेन्ट गर्न मन लाग्छ. मलाई यो क्वेसन प्लिज डक्टरसँग सोधिदिनु होला. यो भिडियो देखेपछि मलाई चाहिँ आफ्नो कुरा अगाडि राख्न मन थियो. मेरो नाम मेन्सन नगरिदिनु होला. के यो पोस्टपार्टम डिप्रेसन हो or something else, where should I go for a help भनेर सोध्नु भएको छ.
नेपालमा हुनुहुन्छ?
हजुर, उहाँ चाहिँ नेपालमा हुनुहुन्छ. मेरो टिकटक भिडियो हेरेपछि चाहिँ उहाँलाई यस्तो थट्स आइरहेको छ. प्लिज एक्चुअली डक्टरसँग सोधिदिनु होला भन्दै हुनुहुन्थ्यो. वाट सी सुड डु डक्टर?
Now, the postpartum depression, it's very common.
Do you think what symptoms she has is a postpartum depression?
Looks like, and it looks like she's a risk as well. Yeah, and then infanticides has happened in the postpartum depression, postpartum psychosis.
Yeah.
Yeah. So, and it's risk to the kid as well.
When you say risk, doctor, what are the risks?
Because she's having these thoughts that she might harm the kid. She doesn't want to, but you don't know when the depression, the black cloud covers you. Like there was a case of, I forgot the name of the doctor. She was a psychiatrist. And she was a practicing psychiatrist in UK. And what happened was she had struggled with bipolar all her life.
Okay.
Yeah, and then in India she was receiving the treatment. Then after that she went to UK, started working, and then what she did was she was self-prescribing her own medication.
Okay.
And then she went to the period of mania. She felt that she doesn't need to be on a medicine anymore. She stopped taking the medicine. And then she started having these thoughts that her son, I think who was 1 or 2 years of age, is evil or devil or something.
Oh my God.
And then she put her son on fire. Yeah, and then after that she put herself on fire. So this incident happened in 2005. So postpartum depression and postpartum psychosis are quite risky.
Sure.
That's why over here, whenever somebody has got the postpartum depression or postpartum psychosis, we refer for at least for a short-term case management, so that there is a case manager there, there is a regular review by the psychiatrist there, and plus we have got this all this midwife, the ops gyne team, everybody, we work together, and there is a separate clinic for them, like a Safe Start clinic or perinatal mental health clinic for them, because it's a risky, yeah, and yeah, with her, what I would recommend is, she has got good insight that these thoughts she doesn't want to.
Correct.
But when this postpartum depression, all this black cloud surrounds somebody, you can't predict. Yeah.
So what she should do now?
I would recommend her to see a psychiatrist soon. Yeah. Start on some medication.
Go and see the psychiatrist, because in Nepal, the system.
In Nepal, it's much more easier. Over here, you have to go to the GP, get referred to the
Correct. That's what I was
psychiatrist. You have
about
to
to
wait
say.
maybe for months. In Nepal, you can go and see a psychiatrist directly. There are a lot of good psychiatrists in Nepal. Yeah.
Yeah, okay. So you recommend strongly for her to go and see the
a
psychiatrist ASAP.
Yeah.
Okay. Meanwhile, what she can do at home, doctor, to prevent not having these thoughts? Can she do something?
Now, in the meantime, look, basically all these negative thoughts are coming there. It looks like we have to do, basically look into her, number one, why these negative thoughts are coming. What's bothering her? Is the husband supportive? Is the in-laws are supportive? Or something happening with the in-laws there, or with the husband there? Is a financial thing happening there? We basically have to look at the cause there, and plus organic. Look at if the medical thing is happening there.
Correct.
Yeah.
Correct.
And then after that, the other, look at the organic, and then look at the cause, what's happening there. Yeah. And then try to basically try to be more positive. If the negative things are happening, just ask her this. She must be literate, all that thing, right? Try
Looks
that.
like.
If you start with the psychological session, I don't know in Nepal, like how many how do the psychologists practice?
Works.
Yeah, but she can print that book, the CBT for Dummies, and do that every two chapters in a
Sure.
week, so that she can change her own thinking pattern. Because she knows that the way she is thinking is wrong, how to change that thinking pattern into more positive one. Or she can do other online CBT classes if she want, which are free.
Yeah.
Yeah.
CBT for Dummies is the one who
Yeah.
you think
So she
should.
can print that, and what the psychologist actually does here in Australia, she can do on her own to change her thinking pattern. Like she knows that's a negative thinking. Now she has to change that negative into more positive thinking. But on top of that, I would recommend for the psychiatrist with some medication as well.
Yeah. Thank you, doctor.
And there are lots, few antidepressants. Like a lot of the antidepressants do react with the lactation as well. So be mindful. There are only few antidepressants which are mother-baby safe, and she has to select that one. The
Sure.
doctor has to select that one, which is mother-baby safe there.
Correct. Again, definitely go and see the psychiatrist.
Yeah.
Thank you very much, doctor. I'll reach out to that sister as well.
Yeah. And then if the family is there, just tell someone what's going on. Don't
Yeah,
keep
go
to
and talk to
herself,
them.
at least to her mom or husband or someone. Talk to other people. Only talking that can. Nepal has got a very good family dynamics there, good family support there.
Correct.
Tell someone what's happening.
Yeah, don't
Ask
keep it
for
within
help.
yourself.
Ask for help.
Don't keep it within yourself. Go and talk to
Yeah.
someone. Thank you, doctor. And I had another question from one of the male listener. He is in Australia and the girlfriend is in Canada. So what he has written is, I don't know and I'm not too sure. And I question myself this a lot. And I hope this will stay confidential, and definitely I'm not going to mention his identity. He was in relationship for 2 years with one of the girl, and now she has gone to Canada. And since she been there, it has been only 2 months, and she has cheated me. And while cheating, she blamed me for all what she has done. So basically, the girl from Canada, she cheated, but then she is trying to blame everything on him. So now he cannot focus on what he needs to do in day-to-day life, and he's keep on thinking about it, and he feels like he's going through the depression, and what he should do to move on his life. So he's kind of stuck in that situation. What do you think, doctor? What he should do?
So basically, as I said, it looks more of a reactive to the
Correct,
social
which we
situation.
mentioned before. Yeah.
So I believe that he is going more towards the adjustment disorder with the depressed mood there. Yeah. On that situation, look, I haven't done the assessment. I can't comment. But in most of the cases, with the adjustment disorder, doesn't need to be any medication.
Correct.
Yeah. Yeah. Usually it goes away. Yeah. But if it persists, like for a long time, then the diagnosis becomes the depression there. So
Correct.
only I can comment like whether he is going through adjustment disorder or the depression after the mental health assessment, or whether he needs to be on medication or not to be on the medication. Yeah. But in the meantime, since he's already in Australia, there's a lot of support there. He can make a mental health care plan to the GP, see a psychologist, and most of them, like not all of them, few psychologists do a bulk billing, few you have to pay out of pocket there. Yeah. And then just Google, call the psychology practice. If he is happy to pay, then that's fine. If not, then look for the psychologist who does the bulk billing. Yeah, and start seeing a psychologist.
Does he need to go and see the psychologist now,
It
doctor?
will be good. Now, depends on how he is coping. If the girlfriend break up, is his thinking pattern, is his mood affecting his everyday life? Is he able to function? Is he able to socialize? How is it impacting his everyday life? If it's impacting, I would recommend to see a psychologist.
Yeah, he did
going to the
mention
GP,
that.
make a mental health care plan, and see a psychologist.
He did mention that he keeps on thinking about her and cannot move on in life. That means, looks like somehow it is impacting his day-to-day life. So, go and see the GP first.
Yeah,
start
and make a
from
mental health care plan, and then see a psychologist.
there. Yeah. Meanwhile, before that, can he do something within himself at home? Or how can he help himself before going to the GP? Or if he does not have that financial situation to go and see GP, what he can do at home?
Is he a student or the
Student.
Then he has to pay, right? Even the psychologist,
Correct.
he has to pay. The bulk
Correct.
billing won't be helpful
Correct.
there.
Correct.
Yeah. So in the meantime, what he can do is the same thing. What the psychologist does is they do the CBT most of the time in the depression or adjustment disorder. And I have already explained what are the things the psychologist does. It's in that CBT for Dummies there.
Correct.
Go through that book.
Sure. And he says
And
he
try
is
to
an
go through the change his thinking pattern, all these negative thoughts, all that thing that's coming, and try to go more into the positive psychology, complimenting himself, all that thing there.
like we mentioned before, thanking
Yes.
yourself, complimenting, and start writing
Yeah.
diary.
Yeah, and then becoming more interacting with the friends, all that thing, and talk with someone, friends, like disclose like what's happening, what's going through my thoughts, all that thing. Even that will help. Talking, communicating.
Yeah, sure. Don't keep any issues with yourself.
Yeah.
Try to share it with someone who you trust.
Yeah.
Yeah. Thank you, doctor. Yep, we covered a lot of things today, doctor. Thank you very much for your time. Now we have come to at the end of our podcast. But before we finish, we have one segment where we call it Chito Chito Mito Mito. It's a rapid fire round, so you need to be very quick. I'll ask you 10 questions, very easy. We'll go through it and we'll finish our episode there. Are you ready?
Yeah.
Sure. It's very simple questions, doctor. So, what is the something that people often get wrong about you?
I don't know.
You don't know. So you think people only think about the good things, or anything like people had misunderstood you and which you are not actually in real life? Someone has misunderstood you.
I don't know.
You don't know. Okay, you don't care what other people think about you.
Yeah.
That's all right. Okay, we'll move to the next question. What is important for you, physical health or mental health?
Both.
You need to choose one, doctor.
Mental health.
Thank you. If you could be remembered for one thing, what it would be?
Helpful. Could do something to the patient.
Fair enough. If you could live anywhere in the world, where it would be?
Duli Hill. That's my birthplace, Nepal.
Oh, how sweet. Sure. If not psychiatrist, what other profession would you have chosen?
Radiology.
Radiology. Good, thank you. What is a common myth you have or heard about mental health?
The people with mentally ill are violent, aggressive. Myth.
And that's complete
That's a myth. Yeah.
Sure, where we did talk about it before as well. What is your favorite one word? One word which you like the most in life? Like, oh, that word gives me a peace kind of thing.
Chilele.
What is that, doctor?
So that's my son. He's 5 now. He sings that song.
Uh-huh.
And whenever he sings that song, that makes me very, very happy. So that's a Hindi song, like Chilele, Chilele,
Oh,
Ayo,
Chilele,
Ayo,
Chilele. Okay.
Masti mein. And he's
Correct.
5. That's the only
Chilele.
Hindi Nepali song that he can sing.
Oh, okay.
And he sings in such a funny way that makes me very happy.
Oh, okay, good. Something, it lightens up your mood.
Yeah.
Okay, that's a good way. What is your worst habit or a very, like a naughty habit when you're very, very young, doctor, from your young time?
Smoking. I used to smoke.
Okay,
Yeah.
when you're young.
When I
and
was
you think
young.
that was not a good habit?
That's a really bad habit.
Sure, let's not discuss. Are you a thinker, doctor, or doer?
Doer.
Sure. The last question, but not the least. If you can travel the time, would you go back to your past or you rather go to future?
I would rather go to future.
Sure. Why?
Because I didn't think my past was fine.
Just wanted to see
Everything
what the future
happened, yeah,
brings.
because my past I met my wife, my parents, how I grew up. Nothing to repent or nothing bad.
Sure.
Yeah.
Just would like to know what
Yeah.
future brings, isn't it?
Yeah.
All right. Thank you so much, Doctor. That's our time. And it's been amazing to have you on my podcast. And in future, if anything comes up, if anyone, because I'm thinking to start one new episode, which is called A Confession, where people are not really able to share their issues with their families, friends, or whoever, where they can discuss here. It's not only related to mental health, any others. If anything, I'll definitely reach out to you, and hopefully you'll be coming again into my podcast. Before we finish, is there anything you'd like to say which we have not captured?
No, nothing much. The only thing is in Nepal, I think thing has to change from bottom to top, like in terms of the mental health. A lot of things need to change there. And since we are in Australia, I think we need to do something as well. Not only blaming the people there or the government there. I think we should initiate as well, which I'm thinking as well, like doing something. Yeah. So a lot of things need to change there. The awareness, the
Education system,
legislation, a lot of things has to change there.
Sure, Doctor. Happy to be part of your plan. If any way I can help you. Being a medical student in the past and now working as a registered nurse, I definitely feel like we need to do a lot for our Nepali community where awareness is very minimum, especially around mental health.
Yeah.
All right. Thank you so much, Doctor, for
Okay,
your
then.
time. Thank you.
Thanks for having me.